why are we here? Well, we're here to come together and discuss collectively, guide the future of research for the use of active surveillance in the management of prostate cancer. And the goal is to really push, together as a group, discuss our perspectives and discuss what should be the future of active surveillance research? What should be the priorities that we as a field look forward to investigating and furthering?
I also want to be very clear that there are no bad ideas today. Indeed, the ideas that are off the wall may turn out to be very good ones indeed.
The broader goal is really to develop these questions in a standard format. You'll hear a little bit more about the PCOTS format of a question, so that in the future, there'll be a research agenda to answer those questions.
My question here, or my comment here, is that each of these 4 levels need to be able to do a significant amount of interaction.
To optimize patient selection, individualize follow-up, and perform patient-centered outcomes and comparative effectiveness research to obtain the data these men need to navigate a complex decision-making process.
You're going to have broad variations in what's happening. Right. So I think when you talk about active surveillance, should they get it, the quality of that care is, I wholeheartedly agree with what everyone else here said. The quality is very much different depending on where they're being seen and by whom they're being seen.
Agree that if access to the information was better or better delivered or delivered in a more cohesive way, that it would make the active surveillance experience better, not just from the standpoint of being safely on active surveillance, but also for the psychosocial effect of being on active surveillance and taking out the fear and so forth and things like that.
I was actually surprised to find that 30 to 50% of patients fall out of surveillance, not because they have to, but because they want to. And I'm sure that there's a multitude of reasons, some of which have been mentioned. Part of it's partly patient anxiety, part of it is family influence, part of it is flat out misinformation about what cancer is or how it progresses.
As a support person, I would just wonder how I could best support the patient, how I could quell my own anxiety and his, how I could get the information and support that I needed, whether diet, exercise, and so on would be of any help.
Although there's a lot of data on active surveillance, really, if you parse the data, it's not a lot of data on active surveillance for Black men.
Patients are a lot of times on their own trying to figure out what's going on. And the layer of support just isn't there for people. And so, it would be nice if there were a way for information to get pushed to people rather than depend on them hitting Google Scholar on their own, trying to figure out what their situation is.
I think the other thing of a 3+4 is, should we or should we not try to aggressively improve the prostate health through diet and lifestyle?
But in looking at that, every doctor that is different, and I'm in the DC area. So the question is, if there's no standardization as far as what you should do, how do you really determine, and especially in my case, I come from a family history of 3 generations of prostate cancer. How do you really determine what's the best approach as far as a diagnosis, whether it's active surveillance or do you take active treatment?
Where we utilize MRI is certainly a topic that we need to understand better, and certainly in the DSM 3+4 space, that cancers can potentially change at a quicker or more different rate than lower risk prostate cancers. Are we able to capture or identify those changes on imaging or identify them up front? All really, really important questions.
The most common issue that I hear, and I'd ask Joe too, is the reluctance to get a biopsy. This is the single issue that I would say, biggest issue that bothers men on active surveillance.
The issue is we don't have data on if the PSA goes up, how much does it go up to say it's progression? Is it just random variation in the PSA number? We don't know from the biopsy results if they're accurate enough that when there's 10% more cancer in each sample, is that significant or not? That's the issue. We don't have the data to make those decisions of what progression is.
When we talk about progression, are we talking about a change in biopsy or something like clinically meaningful like metastasis? We have to just take a step back and remember that a progression to metastasis is such a rare event that you won't see one case out of 1,000. I showed you 905 patients, 90% of reclassification was grade, 10% was volume. Nobody was metastatic. So we have to reorient our level of concern here in terms of what we're missing.
Young men that are good candidates for surveillance, but they may have some higher risk features. Either they're favorable intermediate, African-American race, family history, something that may increase their risk of progression. And that conversation that you have with that person may be a little different than if they were 70, right? And then that's a little bit different from, let's say, a person who you find with truly very low risk tumor, and you're really trying to think about their long life expectancy and how you may be able to de-escalate the intensity of surveillance.
Really, the concept of concordance is really important. So if it's 3+3 and a negative MRI, you could say, well, those two things match. We don't have to do another biopsy. But if there's 3+3 on the transrectal biopsy and the MR shows a big anterior lesion, that would suggest the transrectal biopsy might well have missed something. And for them, we'd definitely go back and do an additional biopsy to check out what the MR said.
I think the point there was MRI alone misses cancer progression, right? But I think that the thing that was missing from that paper was they didn't really look at the percent pattern 4. When there was upgrading, yes, a binary outcome is to go from grade group 1 to grade group 2. But in terms of tumor behavior, as we know from some of the Martini Clinic RP series and so forth, if you have 5% pattern 4, that behaves like a grade group 1.
I think that there's certainly in our country an indication that if all socioeconomic barriers are shattered, like let's say in the armed forces, the difference between races can be minimized.
If you're a 3+4, how panicked should you be? What does the research show? And I think as an AS patient, I would really appreciate that kind of information coming to me through the organization that could give me some guidance as to how fast I need to move and how close I need to be monitoring things.
I think the concern, though, is we have to prove that this perceived comfort and confidence to go on surveillance with MRI is actually, shows to be true from our results of our clinical trials. There may be that person who's in a part of the country with no access to MRI shouldn't feel discouraged.
In the background between Monday and today, there's been a lot of work with a group of people who've been coming together to really analyze all the conversation that took place on Monday. Ultimately, through those efforts, we were able to generate 22 questions, and those questions were able to be divided into 4 groups.
I think this is a good discussion because, we've talked about enrollment as an outcome, but then, parallel or, part of that is also looking at satisfaction with the decision of doing surveillance as well. And I think what you guys have pointed out is this would be worth looking at in low risk. And I'm starting to see the your point in terms of making you feel better about doing it. So I think at least some of the takeaways I've gotten from this question is to look at this from a additive point of view, the genomics to the MRI and see what it adds.
One of ASPI's goals is to help men reduce anxiety. There's so much unnecessary anxiety within the active surveillance community. And if a tool like genomic testing can help that, wonderful. But I don't know whether it can. We'd first have to determine whether the genomic testing actually does reduce anxiety.
We don't need more data. We know the advantages of transperineal approach. And I think there are a lot of logistics issue, a lot of financial consideration, learning curve. And I think as a urologist, we have to overcome those barriers. I don't know if we need any more data, and a little bit more data would not make TP biopsy more feasible and more pervasive in the United States. I think there are other issues behind that.
Probably a better way to roll out these things, both in terms of addressing patients and addressing physicians, because I don't know that we talk a lot about patient education, but we don't talk a lot about physician education and how to make that both financially viable and incentivized for physicians?
There has been one trial that has been done in this space. Level 1 evidence, it was the TUCAD trial, which was photodynamic therapy, which randomized men into Hemi ablation versus active surveillance and looked at progression to definitive treatment. And that was actually a positive trial in that it did prolong the time to definitive treatment.
Does having regular access to a support group help to keep men on active surveillance longer who are still good candidates? Does that help to mitigate their fears so that they don't withdraw and go on to treatment when they're still a very appropriate candidate to continue on active surveillance?
So we have used in a small pilot study this group appointment for follow-up visits for men who are sort of stable on active surveillance. And the outcome there we used was patient satisfaction and anxiety. So I think it was really a useful way of using these group appointments, and patients really loved them. So combining both a medical appointment where they share their journey on active surveillance, but also educational.
Surveillance approach that is as minimally burdensome as possible to the patient is ideal for everyone, as long as we're not compromising safety.
We're focusing on men who've already been diagnosed and now helping sort of understand decision making and how we can facilitate that and optimize information giving. But you're right, there's so much work to be done even before that at the level of screening. And just optimizing screening and making sure that all the populations are aware of what their risks are and what the opportunities are to screen. And it's not really the focus of this conference, but it can't be ignored. It's still such a huge area within prostate cancer research as well.
A wonderful conference. I think meeting all of you virtually reaffirms the fact that the whole system is seeking to improve the health outcomes, both the medical and the health and the research and the community system.
And I think it's one thing when you have an individual say, I have a great idea, like we should study this. And it's another thing when you have a group of 100 individuals composed of patient advocates and patients and academics come together in a structured way, say we think this is a really important idea. And I think that now that we've accomplished that, I'm hoping that we will see some of these projects turn into actual projects, like actual studies.